Welcome, everyone. I can't see anybody, but about Peace Through Health. We called it Peace Through Health, A Way Forward. And I'll explain to you briefly what Peace Through Health is, and then talk about a few examples. And after that, we'll have Kaveh Kushnuth from Yale University speaking a little bit about peace through health and public health, so the public health role in responding to armed conflict. I'll talk about a few examples, and then I and Bree Atchison will talk about a few micro examples from some things that she, who is Wilfrid Laurier University professor, and I, being part of a group at McMaster University, both in Canada, have been involved with. And then later we'll talk about things more at a macro scale with Mathilde Bodart from the World Health Organization Health and Peace Initiative. And if we've got time, I'll tell you a bit about courses and a conference that we're going to have in at the beginning of May 2026. So that's generally an outline of what I propose to talk about with colleagues. Just wanted to do a touch base with Elizabeth and Ian. Is everything okay?
Yes.
Okay, great. And so as I've approached talks before for the last 20 years, I've referred to a definition of peace through health. And in this, on the McMaster University website, with McMaster being the probably the leader or the earliest university to look at these connections between health and peace, and with the development of a Peace Through Health group that studied this, we referred to Peace Through Health as an emerging academic discipline, and it kept on emerging. And in some ways, it's been a rocky course to develop this and develop global attention. But it's been an academic discipline to study how health interventions in actual or potential war zones or zones of conflict may contribute to peace. And I'll explain that very shortly. For many years, people have recognized that war and violence are a major contribution to disease, suffering, and morbidity and mortality. And back about 25 years ago, there was the precursor of the global burden of disease, where people talked about, Chris Murray was the leader of that. He's with IMEC in the University of Washington, and he and colleagues talked about war and violence becoming the 8th leading cause of death in 2020. I'm not sure that it got quite to that, and they've classified that in different ways, but just to say that it is a significant cause of the burden of disease and death. In 2001, the World Health Organization had a report on violence and health, and this was meant to be a more regular report, but they actually haven't done that since. But others are studying the effects of war and violence on health. But at that time, they felt it was causing significant burden of disease. The WHO at that time shared a model of violence, an ecological model of violence, which classified violence into different categories depending upon scale. So that went from individual to interpersonal to community level and to societal and world level. And as they looked at each of these scales of violence, they looked at determinants and risk factors, as you could see in the model listed on the left. But at the same time, many outside of those few of us who study this have not thought about the health sector as being one that can actually contribute to peace. They recognize the violation of war on health, but not that the health sector, unlike the other sectors that the Institute for Multi-Track Diplomacy looked at, that might be able to contribute. The governmental sector, professional conflict resolution people, business, the judicial sector, the religious leaders, all they felt could contribute to peace, but not the health sector. Now, because I can't see everybody, I do hope that people are introducing themselves, where they're from, any background in this in the chat, and I'd like to look at that once I'm not sharing my slides. So please do that. And then if you've got specific questions and comments, please put that in the Q&A, and we'll try to answer questions during our presentation. So please do both of those things. So I myself was involved with teaching the first university course on peace through health more than 20 years ago, and then a little bit expanding on models that people from our university had developed. And we published on this in a journal called Medicine, Conflict, and Survival. And you can find that there on the website if you would like, and also find it on my website, neilaria.com. And we did try to develop this as an academic discipline. In that first article on this as a discipline, once again expanding on the work of colleagues, I talked about the relationship between health and peace, and looking at their definitions, the way that the WHO looks at things, very holistic for health, but also peace studies practitioners also view health very holistically, with integrated, respectful, cooperative, positive relationships. Both are not defined in terms of a negative definition as their absence, with health not being the absence of disease and infirmity, and peace not just being the absence of war or violence. And when we think about each of them, both are considered rights, again, by many in the health sector. The right to health or health care is considered a right, whereas in the peace sector, it is accepted that it should be a right for all, but it's encoded in the UN Convention on the Rights of the Child as a right for children. Each have their own determinants, as I had mentioned about the WHO report on violence talking about that. But those determinants are also paralleled in some ways. And in the Ottawa Charter for Health Promotion, peace was listed as the first determinant of health. And we also can think about the transformations from violent societies to peaceful societies, just as we can think about health promotion as enabling people to have increased control over their determinants of health and improve that. Further, for those thinking about health and peace connections, we probably have to define and expand what peace really is and what power is. And this will be important as I talk about a few macro examples. But I think rather than thinking about power merely as being hard power, we have to think about it as getting what we need as a society, furthering our security and well-being. And as such, we might think about power and security as being protection from physical harm, but also access to resources to meet our basic needs. And security and power, often there's a sense of a feeling. And say we look at the US being the world's strongest power in terms of military might, the strongest power that ever was on the face of the earth, but there's still a feeling of insecurity. And so we have to think about that when we think about power and security. And then think about violence too. And peace studies practitioners have actually looked at violence in a health type way. If you look at the definition in the bottom right, as violence being avoidable insults to basic needs. Or sorry, yeah, so this would be at any level, macro or micro, and war being an extreme form of collective violence, which causes insults to basic needs. So when we don't have our survival needs met, we have death. When we don't have our well-being needs, we have misery. Don't have our freedom needs met, we have repression, and our identity needs met, we have alienation, and all of those things are made worse by war in particular. Peace being the opposite, as you see in the bottom left, where we have our survival needs, well-being needs, freedom needs, and identity needs met. Further, violence can be classified into what is called direct violence, then structural violence, cultural violence, which enables both direct and structural violence, and ecological violence, being violence against the earth. And this concept came from the late 1960s from a great peace studies theoretician, Johan Galtung. So direct violence is the harms that we can see. Often it can be physical, but it could be psychological, social, or spiritual. But you know who the actor is, it's quite obvious, and you see the harm done to individuals. There are other things that are less direct and hidden, and that is termed structural violence. And so those are the processes which prevent us from realizing our potential. And this could be what the systems provide. So the inequalities in income, education, access to resources, access to what the Ottawa Charter looked at as determinants of health. So you don't normally think about that as violence, but in terms of reduction of human potential, it is. Cultural violence refers to the belief systems that we have, the ideologies, language, art, science used to justify both direct and structural violence, the isms, so racism, sexism, nationalism, and then ecological violence, as I mentioned, was violence done to the earth. And we could look at violence as we mentioned in terms of its scale, from micro to meso to macro. And summarizing this a little bit, so as I mentioned on the left here, that Johan Galtung talked about negative peace and positive peace. So promoting positive things, being positive peace rather than merely the absence of violence or fear. And we each recognize in the top right that war causes disruption in social systems or structures and also causes health deficits. Looking at the bottom right, what we hope to do with Peace Through Health is look at how health workers and health perspectives can diminish both direct and structural violence. And I hope you'll get a sense of that today. So I use a few examples, which I'll go over really briefly. As I mentioned, teaching courses, we have like a term of weekly 3-hour lectures normally. But just to tell you that when people at McMaster tried to look at health peace initiatives, they tried to look historically at different examples. And going back to ancient times, you could talk about in Greek plays about women withholding sex as a way of stopping men from engaging in violence as being an example. But I use the example of Henri Dunant in 1859. Henri Dunant was a Swiss businessman, and he wanted to get concessions in Africa, in North Africa, to do business. And at that time, you had Louis Napoleon as the leader of France, controlling that area. And so he thought he would go down to see this descendant of Napoleon Bonaparte in northern Italy, where he happened to be. But at that time, unbeknownst to him, there was a battle, the Battle of Solferino, between the Austrian Empire and the French. And this was among the bloodiest battles of the 1800s. And so Dunant arrived there just after the battle had largely finished and wasn't able to meet Napoleon, but he was shocked by what he saw. And he saw various damage to houses, as you can see in the middle, but he saw soldiers lying in the field, not dead yet, but not able to be treated, receiving no care, and suffering mental health consequences. And this really scarred Dunant from having witnessed this. And so he mobilized local women to help tend to these soldiers in the field with what basic things they could. But then he went back to Switzerland and thought, we've got to do something about this. This shouldn't be happening in the 19th century where they were civilized. He ended up getting together people representing various governments around, like France, Germany, Switzerland, Austria, and formed the Red Cross. And you see the Red Cross is its emblem is the inverted Swiss flag. But at the same time, Dunant went further than creating this health organization. He went to get these governments to agree to regulate the rules of war and develop the first of the Geneva Conventions. And Dunant won the first Nobel Peace Prize in 1903, I believe, and the Red Cross has won it 3 times. But this was an intervention based in health, not by a doctor or nurse, but a businessman. And we believe that that's helped reduce violence. So that's why we consider this to be the first example of health peace initiatives. Another example that some of you here are familiar with is the development of International Physicians for the Prevention of Nuclear War. This is an organization that I have been part of and since the first year in medical school, and that happened to be the year that IPPNW won the Nobel Peace Prize, 1985. So why did this organization develop, and how did it help lead to some semblance of peace? So back in the 1950s, you may recall, most of you would not have been alive. I wasn't alive then. People were talking about nuclear weapons, uh, not just keeping the peace, but actually as a major thing that we needed to expand on. And so at that time, the US and the Soviet Union each had weapons and were planning to basically destroy each other. They were thinking about winning a nuclear war by killing 50 to 100 million of the other side, even if they lost 25 to 50 million people themselves, something that many people now think is ludicrous, thinking about winning a war. But at that time, lots of people were having their own backyard bomb shelters. And in the early 1960s, the founder of IPPNW, Bernard Lown, the US founder, was involved with a paper in the New England Journal of Medicine, basically saying that a nuclear war could not truly be won, that if you had an attack on Boston, for instance, you would have 98% of physicians, nurses dying. You couldn't develop a medical response to treat victims. And therefore they argued it shouldn't be fought. Lown was friends with Evgeny Chazov, a Soviet cardiologist, and each were experts in sudden cardiac death. And as they were talking, they found that, well, why are we trying to save individuals in terms of this sudden death when we're killing people in the millions with our plans? They formed an organization, getting colleagues together, and this was IPPNW. We see this as getting cooperation between two warring sides, looking at health as a superordinate goal. But their ideas that nuclear war couldn't be won ended up influencing Mikhail Gorbachev, who was the leader of the Soviet Union. Even prior to Gorbachev, Chazov, being a cardiologist, had been the cardiologist to much of the aging Soviet leadership. So there was some things where their arguments ended up affecting the Soviet leadership, and then later even Ronald Reagan to some degree in terms of disarmament. And Gorbachev credited IPPNW in his book Perestroika with changing his thinking. So once again, turning this issue that belonged to the generals and politicians into a medical issue. And I think I'm going to stop here for a second, and I'm going to check the chat for any questions, but I'd like to leave the floor for my colleague Kaveh, Kaveh Kushnud, and Kaveh's at Yale teaching in public health for many years and developed this interest also probably 20 years ago. Kaveh, are you ready to share slides?
Yes, I am.
Okay.
Let's see. Can you see it?
Yeah.
Oh, perfect. Well, thank you so much for inviting me, Neil. I really appreciate being with all of you. Let's see. So I feel like some of the things I wanted to talk about, Neil, you already mentioned, but I'll go through it. So basically, my talk frames armed conflict as a central and preventable determinants of global health. And the aim is to move beyond viewing war only as a humanitarian or a security issue and to recognize it as a core public health priority. And I will use this peace through health lens to show how public health tools like surveillance, prevention, documentation, advocacy, they can help reduce harm, inform diplomacy, and contribute to peace building. Okay. So why armed conflict is a public health emergency? I think Neil already mentioned a lot of this. Armed conflict creates conditions in which most deaths and much suffering are preventable. WASH, which many of you know, water, sanitation, hygiene. When it collapses, there are outbreaks, there's interruption of maternal chronic care, health system shutdown turns conflict into sort of a population-wide health emergency. So here I want to underscore that from a public health perspective, war is a predictable risk factor for disease and premature death, one that we can study, anticipate, and work to prevent or mitigate it. So how war destroys public health system. On this slide, I walk through how war dismantles every pillar of a functioning health system. Power and fuel shortage disrupt neonatal care, dialysis, oxygen supply, surveillance systems like EWARS, which is early warning, alert, and response system, IDCSR, which is integrated disease surveillance and response, breaks down. Health workers are displaced, injured, or actually targeted. Mass displacement multiplies infectious disease and undermines continuity of care. So the key point is that these are systemic failures. They're not just isolated events, and they can be analyzed and addressed using public health tools. So some of the predictable patterns across the conflict. So across Sudan, Gaza, Yemen, Ukraine, Syria, and other settings, we see strikingly similar patterns, major outbreaks, attacks on health facilities, disruption of WASH, mass displacement, and excess winter mortality after infrastructure collapse. So I want to emphasize that these patterns, again, are not random. They highlight the need for earlier risk assessment, stronger protection of the health system, and rapid informed public health response whenever conflict risk rises. So these are sort of this slide introduces the four responsibilities that structure the second sort of half of my talk, which is one, documenting the harm, mitigating its health impacts, advocating for protection of civilians and health workers, and contributing to peace building and prevention. These responsibilities are firmly grounded in public health's mission of prevention and population level well-being and are consistent with American Public Health Association call, which goes way back 2 decades, that was the call to treat war as a public health issue. Okay. So starting with documenting harm. Documenting the health consequences of armed conflict is an active public health intervention. It's not a sort of a passive academic exercise. By the way, back in 2021, I was able to launch a humanitarian research lab at our School of Public Health. And the focus of humanitarian research lab has been documenting exactly what I'm talking about. Attacks on hospitals and other health facilities. Mostly the work we've been doing has been in Ukraine, Sudan, and we've done some work in Gaza as well. So without sort of reliable data on mortality, as you know, civilian mortality in conflict often is not something that has paid attention to. Morbidity, displacement, attacks on health system. It is impossible to advocate effectively and allocate resources fairly or hold perpetrators accountable. So it's really important to document. Here I highlight the role of epidemiology, health facility data, satellite imagery, which is exactly what my team has been doing, open source verification, OSINT, which is known as open source intelligence, where you're systematically able to collect, analyze publicly available information from social media, videos, satellite imagery, news reports, etc. So I stressed also the importance of ethical, non-extractive approaches that respect the safety and agency of affected communities. You don't want the data that you analyze and send the public report to end up actually harming the people. So I have to be very sort of conscious of that. Okay, so this slide focuses on sustaining, sort of mitigating harm, focuses on sustaining essential public health functions during conflict, even under extreme insecurity, supporting continuity of ANC, which is antenatal care, also emergency obstetric and newborn care, immunization, trauma care, NCD, which is non-communicable disease management. They can drastically reduce preventable mortality. I also emphasize decentralized surveillance. I mentioned EWARS, IDSR, also community health workers, mobile clinics, remote support models, and the importance of maintaining WASH, nutrition, and outbreak control system. Often overlooked, health workers' security and pre-positioning of supplies are critical elements of harm reduction. In terms of advocating for protection, here I'm going to frame the advocacy as a core public health responsibility. This is not partisan activism. It is the translation of evidence into action to protect civilians and health workers. I can illustrate how data on attacks on healthcare, civilian casualties, WASH collapse are used to argue for humanitarian corridors, respect for international humanitarian law, protection of critical infrastructure. It is also important to highlight engagement with governments, with UN agencies, with NGOs, journalists, legal bodies, and to underscore that centering local voices is both ethically and strategically essential. Evidence-based advocacy directly shapes diplomacy and can save lives. In terms of advanced peace building, this slide connects peace building explicitly to public health practice. Because war is a modifiable determinant of health, public health has a legitimate role in conflict prevention and peace promotion. I describe how early warning system, violence risk monitoring, trauma-informed community programs, and efforts to strengthen social cohesion all contribute to reducing the likelihood and severity of violence. Addressing structural drivers such as inequity, exclusion, injustice, environmental stress, they align public health with sort of broader peace-building agendas and require integrating conflict sensitivity to education, research, and policy. And by the way, to my knowledge, unfortunately, not all the schools of public health pay attention to this topic. They don't have like a required course on this topic. And by the way, I teach a course called Health in Humanitarian Crisis, and it's considered an elective. It means it's not a required course for all public health students to take it, those who have an interest. But I do think that schools of public health need to bring more attention to this topic. So I want to close by, in closing, I want to bring the argument sort of back to the three main points. The first, armed conflict is a preventable public health catastrophe. It's not an inevitable sort of background condition. Second, Protecting civilians and health workers is a core public health obligation that demands rigorous documentation, targeted intervention, and strong advocacy. And third, public health evidence must inform diplomacy, ceasefires, humanitarian access, and long-term recovery. Preventing war and reducing its harm are among the most impactful population level interventions that are available to us. So I want to thank you. One second. I want to end up by thanking the audience and inviting collaborations because for those who are working in global health, humanitarian response, and peace building, I encourage you to consider how public health framework can strengthen your work in conflict setting. I also welcome any follow-up conversation about research, training, partnership, focused on the health impacts of armed conflict and the role of peace building in public health. Thank you very much.
Yeah, thank you, Kaveh. And I see comments here. Marion from Liberia had a comment also in the chat that I don't know if you want to address related to coalition building. And I will also address that later. But in the meantime, if you could answer that, but also could you share something more about some of the micro level projects that you've been involved with in Sudan or other places? I think
Right.
people would be interested in your work.
Sure. So again, you can do a quick search or I can put in the chat the Yale Humanitarian Research Lab. I had the pleasure of launching it in 2021 with my colleague Nathaniel Raymond, who has been working on war crime accountability for well over 2 decades. So his particular expertise is open source intelligence data, analyzing that, and particularly satellite imagery, which some of you hopefully have come across that. Using satellite images, you can actually see what's happening on the ground almost at the same time, right? So we have been documenting, my team has been documenting attacks in Sudan. And unfortunately, Sudan is not getting as much attention as it requires. It is absolutely the worst humanitarian crisis globally. I know there's, of course, the situation in Gaza is also horrible. There's definitely famine in Gaza, but there has been famine in Sudan for well over a year and a half at the highest level. But Sudan is not getting much attention. But that's why I think my team is really releasing reports on a very sort of sometimes weekly or daily when they have access to satellite images that show what attacks are happening on the ground. They release the report, and thankfully, there are journalists who almost immediately reach out to us, ask us to have a conversation with them, maybe interview, and even sometimes they want the data. And we have been in close conversation with International Criminal Court under the Biden administration, but unfortunately now we're not able to do that under the current administration. So, of course, it is challenging, but I think it is this the using satellite imagery to document what's happening. I think it's a very innovative and strong way to do this. And yeah, there's a lot to be said about that. But again, I'll put it in the chat because our reports are released publicly, so anybody can have access to them on our website.
Okay. No, thanks, Kaveh. Bree, did you have a question or comment for Kaveh? And then I'll move on with the presentation and get you in a little bit later too.
No, I'm good. Thanks, Neil.
Okay. Okay. So thank you, Kaveh, for highlighting different roles of public health here. Let's see. Now it says I can't share my screen. Oh, there. Okay, that's good. So we'll move on a little bit and we'll talk more about examples and maybe even a little bit about coalitions that Marion had asked us to discuss. So it's really great to see people from zones of conflict here today, and I wish we could actually get people to be able to speak. I see some of my students from our McGill distance course who are here too, and many of you had really important things to share from your zones of conflict. But hopefully we can connect later, and I'll talk about our Pegasus Institute as one of the avenues where we can connect for those with this interest. After I speak for a few minutes and then get Bree, we'll be talking more about the World Health Organization, Health as a Bridge to Peace, and the Global Health and Peace Initiative. But I just wanted to share one other example related to public health and peace. And this is from Central America in the 1980s. As many of you may not be aware, back in the 1980s, Central America hosted several different wars in Guatemala, in El Salvador, Nicaragua, and the neighboring countries were also affected. And at that time, there were tremendous health consequences related to this. I think 70,000 people died in El Salvador over that period of time, a country that now has about 7 million people. But one of the things that they saw was that children were dying, infants were dying. UNICEF, headed by James Grant, an American at that time, was really distressed by this. And among the causes, they thought that lack of immunizations was an issue. The infant mortality in the countries at war was about 80 per thousand. And now in many of our countries, it's about 3 per thousand. But at that time in the neighboring countries, it might have been about 25 per thousand. And immunizations would only be part of that explanation. But they decided that they would, that UNICEF and PAHO and the Catholic Church felt that they should act on this. And so that PAHO had a relationship with the Salvadoran government at that time, led by Jose Napoleon Duarte, a rightist figure. And they went to the Duarte government and said, "Your children are dying. Why are you fighting?" And of course, Duarte's response was, "We're fighting for our children, but then they're dying right in front of you. And one of the reasons is lack of immunization. Is there any chance that you could avoid fighting for a little while?" And Duarte said, "Yeah, of course we could. But the other side, they don't care about their kids. They'd never agree." And at the same time, you had the Catholic Church, which had a lot of support amongst the rebels. Their leaders went to the rebels and said, "Your children are dying. Why are you fighting?" "Well, of course we're fighting for our kids." And they once again said, "Well, would you agree to not fight for a little while so we can immunize your kids?" And once again, lack of trust with what the government would be saying. And in the end, they said to each side, "Well, you guys go home at Christmas most of the time. You don't fight then. Can you at least agree to not fight at Christmas?" And in the end, both sides said, "Yeah, the other side will never agree, but yeah, we do." And in the end, Christmas 1985, they ended up immunizing 200,000 kids. And every year, 2 or 3 times a year, till 1992, when peace accords were signed, they managed to immunize 200 to 300,000 kids. Infant mortality, incidentally, went down over that time, not all related to this, but went to about 40 per thousand. So we see this as a success as a health initiative, but we also see the two sides agreeing to what might be considered a superordinate goal, their children, their well-being. The fact that they could come to an agreement was something special. The fact they could view a future without war. And so we believe that this initiative helped lead to peace. That particular example has been criticized, and when they've tried to replicate this in other zones of conflict, sometimes when people stop fighting, the sides rearm, or they use that to gain resources. But many people do believe that this helped set the conditions for peace in a rather imperfect way. So that's one of the examples that we think about. At the same time, as I mentioned in the top right of this diagram, that McMaster University scholars looked at other places where conflict ended and where health might have helped lead to things, develop mechanisms, which we don't really have time to discuss. And Marian talked about coalitions. I talk about different organizations in the bottom right here, but what we looked at was where we might intervene. And another group at McMaster with the Population Health Research Center or Institute, PHRI, looked at war like cardiovascular disease and looked at where we might look for primary prevention, secondary prevention, and tertiary prevention. So tertiary prevention being rebuilding, secondary prevention during war, mitigating the effects of war, primary prevention looking at before you had a large outbreak of violence, and then primordial prevention, the causes of the causes, if you think about risk factors in cardiology, but also for war, and looked at where organizations or individuals might act. And so I mentioned a few of these in that paper from 20 years ago, IPPNW, which some of you do belong to, as a primary prevention organization related to war and weapons of mass destruction. So if we look at that, or organizations working against gun violence, that might be considered primary prevention. If we look at the secondary prevention, organizations working during war, like Médecins Sans Frontières, the ICRC, and then tertiary prevention, some of the projects that I'll talk about with McMaster University, and Bree may even talk about some of her work. And then before then, looking at some of the roots of war, primordial prevention, some organizations dealing with human rights, governance. And so these various coalitions, Marian, are ones you could consider joining or developing yourself, working with others. But you have that 40 years experience that many of us don't have. So I'd be interested in hearing your ideas, maybe separately after. I think I'll skip through this in terms of our timeline of Peace Through Health. I don't think that that's so useful. We produced a lot of papers in the late 1990s and early 2000s. Those are just some of them in BMJ and the Lancet, and looking at these mechanisms. But at the same time, we developed some projects with McMaster University that I'll just talk about as examples. Bree has much more recent examples of work that she's done. McMaster got money from the Canadian government as it signed the Conventions on the Rights of the Child to study the effect of war on children in war zones. And so at that time, Rob Chase, who's a colleague who had been a medical student at the time, and then went to study occupational health. He went to study people in 3 areas of Sri Lanka and found tremendous rates of PTSD, children who had, majority had seen dead bodies, 10 to 15% had had a close relative who died. But basically 95% of people were at risk for PTSD. And with some of you being mental health professionals, you think, well, maybe we'll send Canadian or US psychiatrists there. But obviously, with 95% of the population there, you're not going to look at a mental health response with medical doctors, social workers. And so Rob came back a bit depressed and said, here, we've studied this. We've done it perhaps for our own good, but we haven't really contributed to people there. And so he was perhaps bemoaning this, sitting in a cafe, and he met a Catholic, well, actually a lapsed Catholic priest, Paul Hogan, who was an artist. And Paul and other artists had been going into a center for neurological rehabilitation. So people in Toronto had, being a specialized center, they would have people coming from all over Ontario, so like 3,000 kilometers away for neurosurgery. And at that time, they would come with their families. You might have 2 or 3 kids in a family coming, and the kids had nothing to do. So the artists got everybody together, and this is just the area that they had was just south of the hospital, and they got kids playing, doing different things, working in nature. And so when Paul and Robbie were talking, they said, oh, wow, this is something very interesting. This would give hope to some places. Could it be applied in a zone of conflict like in Sri Lanka? And Paul went to this area, Batticaloa in eastern Sri Lanka, where Hindus and Muslims had been fighting, and then talked to teachers, talked to a Catholic priest there. There was an old abandoned Catholic school, and they said, oh, well, we could use this school to develop something, and talk to local artists. With the teachers, they agreed that these artists could take people off their hands for a Wednesday afternoon or Saturday. Again, the people that they would take were the kids who were acting out, and often they were the kids, as you know, who'd be most traumatized. So they got the kids out of the school, they got the artists together, developed this village. They used a bit of a fishing motif because the area was an area where they had fisheries. And they brought kids together from the Hindu villages and the Muslim villages. And the kids, of course, having been told by their parents that that people from the other side killed your uncle, there was a bit of mistrust. But unlike adults, kids more quickly put that aside. And so with these buses, after a few days going from one village to the other, gathering the kids, bringing them for an arts program, found the kids developing some trust amongst each other and playing. So the artists did what was called earthwork, artwork, heartwork, and healing. And so, again, getting people to play, creative arts type things, working individually, making a little design, playing with animals, planting things. And we believe that that helped lead to peace. Rob went back to do a study several months later and found reduction in trauma, but also improvement in people's attitudes. And this garden, the butterfly garden, if people want to read about that, still exists now almost 30 years later. So this is one example from McMaster. This example I'm going to go through. I won't really go through, but Rob had also been involved in a study of child morbidity and mortality after the 1991 Gulf War. And this was meant to share what the effects of war could be, and they advocated against things like sanctions, which may have led to the death of 500,000 people, 500,000 children in the late 1990s, early 2000s, and many of us advocated against the 2003 war, which I think most people agree was not a success now. In Afghanistan, the same sort of thing. We proposed alternatives to war. We had a group from McMaster which went into refugee camps prior to the Taliban being overthrown in 2001. It was meant to teach more peace to kids, but at that time, the adults there from different conflicting tribes said, "You should teach us about peace." and so they developed a book of stories and a puppet show. But because of illiteracy there, translated into Pashto and Dari, the two main languages. And this book of stories, which teaches about PTSD and mental health, but also teaches against othering people, that is available on the journeyofpeace.ca website. But once again, even though most of the people who were involved in this were very anti-Taliban, we talked at that time about the bombs not being the answer and alternatives to war at the time to accomplish the goals after 9/11. And in El Salvador, I've also done some talks on peace through health. I'm going to skip through all of that. And I think this too about war being a man-made public health problem, other than to say that we have tried to get people, even in the U.S., to think about how you can engage in primary prevention rather than spending $1 trillion a year on defense. So I'll skip through these slides, and then we'll come back to the health as a bridge to peace. But I want to go back now to Bree, if we can. I'll just see there are some other comments in the chat, but I don't see any other questions. So why don't we move on to Bree, and I can come back to other work later, but please do put other questions and comments in the Q&A and introduce yourselves in the chat. Thank you.
Hi, thanks so much, Neil. Can you hear me okay?
Yeah.
Okay. I had a bit of a spotty internet connection, so I just switched over to a different connection. So hopefully this will last for the time that I'm talking. But thanks so much for inviting me, and really great to learn more about the Peace Through Health initiative that you described, Neil. And I've heard some of the stories, but some of the stories are new, so really interesting to hear. And thank you for having me here. Really great to be connected with the public health community. I'm actually a professor in the Faculty of Social Work at Wilfrid Laurier University up here in Canada, and but I do have a public health background. So my background is I have an MPH from Columbia at the Mailman School of Public Health. And global health is really my passion, but I love combining social work and public health in the work that I do. So I wanted to share some of the projects that I'm working with that I think could be good exemplars for this Peace Through Health approach. I do want to acknowledge I have a lot of community partners. I know Neil does as well. All of us have so many community partners that wouldn't even fit onto a slide, all the people that we work with. I have a few of the names at the bottom of this slide of the people that are working on some of these projects, but they're vast, the people who help these projects to succeed. The projects I'm going to talk about today are taking place in the Rohingya refugee camps in Bangladesh. Let's see here. So just to give an overview of the situation of the Rohingya, There are, I guess it was back in 2017 when there were about 700,000 Rohingya who were fleeing genocide, ethnic cleansing in Myanmar. And 700,000 fled over the border in just 10 days into Bangladesh. Today, there's over 1.2, about 1.3 million who are living in the camps in southern Bangladesh. And these are the world's largest refugee settlements. They're really crowded, extremely overcrowded, and really resource constrained. And that has become even more apparent and more of an emergency this year with the cuts in USAID funding, which have really put this population on the brink of starvation, and it's quite dire there. So refugees there in Bangladesh are also facing many challenges due to the hosting mechanism. So they're being hosted by the Bangladeshi government, and the Bangladesh government has been lauded for allowing this many people to come into the country and to seek safety. But at the same time, they're also discouraging the Rohingya from staying in the country. So they're actually not called Rohingya refugees. They're called um, um, forced forcibly displaced Myanmar nationals, and that is to indicate that they are from Myanmar. They're not from Bangladesh. They are from Myanmar, and that they should go back to Myanmar eventually, and that they've been forcibly displaced, and that they are, these are very political terms, right? The other things that the government has enacted is limited access to education. So there's no formal education beyond grade 3 for the refugees, and that is because they don't want the population to stay, and they don't want them to take jobs from Bangladeshis, things like that. And that is also connected to livelihoods. They don't allow Rohingya refugees to work. So these populations, these families are solely dependent on humanitarian aid for their survival. There's also high rates of, maternal child health issues. There's high rates of health issues generally. Not a ton of access to health services, even though there are a lot of NGOs that are doing wonderful work there. And the population is highly vulnerable to malnutrition, disease, and psychosocial issues, high rates of gender-based violence, high rates of hepatitis, things like that. So it's a pretty dire situation, and families are really struggling. You can see where the populations are are settling into these really, really crowded camps in the southern Bangladesh region. So you can see that the places here on this map from UNHCR. On the north map, the Kutapalang registered camp, that has the majority of the refugee population, and that's where we are doing our work. So we're working with Hope Foundation for Women and Children of Bangladesh. It's a really wonderful organization. We're so lucky to have this community partnership with them. Established in 1999, it's a nonprofit that provides healthcare education, humanitarian services. It runs hospitals. It originally was running hospitals in Bangladesh proper, and then the Rohingya refugee crisis occurred in 2017, and so they were able to open up places like this Hopefield Hospital in the camps and actually be providing care for people. They were one of the first hospitals to open up in the camps. And from there, they've been providing, clinics, community health programs to not just the host country, but also to the Rohingya refugees. And the Hope Foundation believes so much in that connection, or in that providing services for not just the populations that are in need, like the refugees, but also for the host populations, and that decreases tension. That is a way to say, we're providing services for both, because that can create tension if there's one community that's receiving services and another who's not. And there's a special focus on maternal child health and women's empowerment, underserved populations. But I think one of the reasons we love working with Hope is because they also do understand that it's not just maternal child health, but it's also family health, and it's very much all the systems. So they do have this systems thinking approach in the work that they do. So I'll talk about the three projects that we're doing. Our one project we call it the Rohingya Perinatal Project, or RPP, and it's really focused on family well-being, psychosocial support during the perinatal period. So we interviewed families, 32 families interviewed over 3 points in time, and we recruited the families based on the mom being pregnant at the time of the first interview. And we're really interested in learning about what are the supports you're receiving or not receiving. How do you feel having a new baby to, to take care of and to feed and to support? And what kind of services would help support you and your family. So we've interviewed families 3 times over the course of 2 years. And really, we're just transcribing, analyzing the data right now. We have another project that's looking at the kind of connection between climate change related disasters and conflict. So these families have, when in Myanmar during ethnic cleansing, genocide, and the violence that they experienced, lost a lot of their homes. So there's satellite imagery that shows the communities just destroyed and homes destroyed. So we're interested in learning, okay, they've gotten to Bangladesh, they have relative safety, but they have this threat of climate change impacting their homes, maybe destroying their homes due to monsoon rains and flooding. So we're interested in the families' experiences of climate stressors and environmental instability. And we've interviewed the 15 families. We've had 5 peer group discussions and 11 community experts. And then the third project is a health assistant training program. And this program is pretty much a model in the region. Now, I mentioned before that the government does not allow Rohingya to be educated beyond grade 3 and also to have a job, a formal job. So this program is quite remarkable in that Hope Foundation was able to convince the government to support this program and to train young Rohingya refugee women to become health assistants for midwives in the community. And this is a model of gender empowerment, women's leadership, but also, resource scarcity where, filling a gap of having these health assistants there who can help educate their communities, their own communities. And women will listen because these are women from their own communities. So this is a program that has taken place over the last few years, and we are currently doing a program evaluation of this project where we're interviewing the families, so the mom, dad, and the girl, young woman, as well as community experts. The methods we use in these projects are pretty diverse, multimodal methods that really try to get at the experiences of families and also serve as a tool of empowerment at the same time. So we do collaborative family interviews where we interview the whole family. We don't just look at the woman or the father or the children. We're looking at everybody, and we're getting their multi-generational family narrative together. And it's a really great process where everybody sits together. We are also entering the homes, sitting with people in their homes, meeting them where they're at, which is I think can be very important for the families that they don't have to come to like a clinical setting and be interviewed. We ask the children to get involved by doing drawings of their homes, their communities in Bangladesh, their dreams for the future, and they love getting involved in the drawing process. And that's a great mechanism for us to be able to ask about their situation in a way that children find accessible. The family interviews aren't going to get at things like gender-based violence or some of the relational issues that families are facing. So we do individual interviews with moms and with dads and with the young women from the health assistant training program. And we also engage young children in a life storyboard method. This is a method that was actually spearheaded by Robert Chase, who Neil mentioned earlier. And it's a way that children they play a game where they talk about their life and they reflect on their experiences, their relationships, and their circumstances. It's very tactile, very visual, which suits children's ways of knowing and communicating. And then finally, for the climate change study, we did peer group interviews where we gathered fathers together, we gathered mothers together, children, youth in kind of like groups that were able to kind of discuss their mutual experiences. So I'll just end by talking about how these 3 projects exhibit what Neil has talked about in terms of a peace through health approach. So in terms of the first project, although all of them kind of cover a lot of these elements in their essence, this idea of reducing family stress is really important. So families really described constant worry about things like for the perinatal project about childbirth or about having another baby or supporting another baby. families oftentimes talk about economic precarity, which is a big issue. And I found in my work, I'm a mental health clinician, a social work clinician, and I'm always attuned to trauma. But what I'm hearing more is just the families are less concerned about trauma or mental health and more concerned about this economic precarity. How am I going to feed my children? How am I going to survive the next day? So these projects can help to reduce that family stress in some way. And I think even just the regular check-ins and the psychosocial interviews that we're conducting with the families over time helps families feel less alone and like somebody's listening. And so I think that that's really important. In terms of strengthening care, we are interviewing the families, mothers, fathers, but also the support network. So we're including in-laws and grandparents and uncles and things like that who join in this collaborative interview. When moms are talking about their needs, they're also talking in front of their husband about what their needs are. And that can be very important for strengthening care. For the climate change study, we're looking at, how our research can reveal disputes that are triggered by scarcity, by resource scarcity, environmental scarcity, and climate change disasters. We're working towards enhancing safety and stability through our findings and through our research. Kind of this idea of the communities sharing these understandings of what the risks are in their community and coming up together with solutions to solve them. And this knowledge exchange can really enhance preparedness for environmental risks. And then for the health assistant training program, we're hoping that the project itself will increase community trust. It's education where an education is disallowed, and working with trusted community organizations that can help to develop that community trust in a community where trust isn't always, assumed. Also, working towards gender equitable norms. So, girls and young women in the community are gaining respect as health actors, as health educators, which is very important. And the families that we've talked to have described a pride in their children, especially the fathers will say they're proud of their daughters for their public health contributions. And that's, I think, a big step in terms of looking at more gender equitable understandings of their situation. And then just encouraging cooperation as well. What does this look like in terms of the peace through health mechanisms? There's really trust building across households and genders and generations. There's an idea of kind of strengthening the communities if possible. That's something that's really important in these settings. The idea of supporting dignity, agency, and hope. Dignity is something I'm really interested in my research and how we can maintain dignity, how we can support dignity, because I think it's something that's oftentimes lost in humanitarian situations. Also, reinforcing caregiving networks, looking at caregiving as not just a mom and a baby, but looking at the fathers, looking at the in-laws, looking at the support networks within the communities to help support families. And enhancing the stability of overlapping crises. We're not just looking at one crisis of displacement, or we're looking at these overlapping crises. So with the Rohingya, it's the initial crisis of having to leave, not to mention the historical crisis of how they've been treated by the Myanmar government over generations. And then once they're in Bangladesh, what the environmental risks are, and that's another crisis. And then the other crisis could be the US aid cuts that is really impacting the communities there. And how do we enhance stability in that context of crisis? And the idea of psychosocial healing and how important that is. And what does that look like for peace? It looks like stability. So families are developing coping strategies for climate change, for postpartum stress. Social cohesion, neighbors are collaborating on things like fire risk mitigation in the communities, which is a big issue for them. Gender equity, we're looking at young women who are assuming these public health roles in the communities. We're looking at trust, where families are trusting the community, the researchers who are coming in, hopefully, and also the organizations that we're working with. And then there's this reduced tension where, the shared caregiving can really reduce household conflict and community conflict as well. And then a shared well-being where families really express a unified hope for the future of their families and their children. Here's a picture of there was some pictures from our research and the teams, our wonderful research teams that we work with. And also just the families who've really shared so much with us. And I love going to Bangladesh because I love sitting with the families and hearing their stories and sitting with them. And they're quite generous in their time and their information. And thank you so much. This is our information if you want to look us up. We're in the process of developing a new website where we're going to have all of this information about our projects. But you can look up Global Diversity and Wellbeing Research Group, or you can send me an email, and I can send you the new website once it's up and running. But thanks so much, and happy to answer any questions as well, Neil.
Yeah, no, thank you, Bree. Yeah, people can't verbalize their questions. They've put things in the Q&A. I haven't seen the second one. I see there was one question more about approaches there in the Q&A in terms of perhaps really our more reductionist scientific method type things and looking at a more holistic type of thing from Brazil. And I would tend to agree, but I think that the question itself was also a little bit complex. So please do email me and I'd welcome that discussion. I've talked a little bit about that and written a little bit about that. And then Carmel's question, Carmel, who's a professor in Lebanon, that also, I think it relates more to what Mathilde's going to talk about here about adapting peace through health strategies in contexts related to stress, conflict, financial crisis, and also something on evaluation of impact. And so I put some stuff in the chat, but I think that Mathilde might answer that more. Bree, did you have anything that you wanted to say about those particular things? And then there was another, let's see, another comment congratulating you about giving concrete examples. A couple of people really appreciated that. But did you have anything else you want to say?
I'm just looking through the questions right now, and I think everything is answered, but if there were, I'll kind of go through them as you keep talking, Neil, and I can always answer them on the chat. But I'm not seeing anything right now.
Okay,
Thanks.
great. So I'm just going to show one slide here, and then I will leave things to Mathilde. So this is related to work that we did with the American Public Health Association. There's a primary prevention of war group that had developed. We developed a paper on the role of public health in terms of the rationale and competencies related to peace. But our group then saw a report from the Institute of Medicine on preventing psychological disorders. And they talked about various forms of treatment and ways of approaching mental health. But we said in this, in a critique of the report, while the report reviews measures to protect service members from the negative mental health effects of war, it avoids mentioning the most effective measure, the prevention of war and the non-deployment of service members to carry out war. So much as we've been talking about, and we did this provocatively to say, well, why don't you guys in the military or those doing consultations for the military think about preventing war? The Institute of Medicine, of course, gave this response here saying that their role was to give unbiased, evidence-based advice, not decide on war justification, and assessing whether reasons for going to war outweighs deaths and injuries is a moral and political judgment, not a scientific one. And so I would argue that we do believe that we can make these things a scientific one, developing methodologies and also, as Carmel mentions, thinking about evaluation. So I'm going to stop my share now, and maybe we can go to Mathilde, who's helping to lead or coordinate the World Health Organization Global Health and Peace Initiative. So welcome again, Mathilde. Thanks for agreeing to be part of this. So please go ahead and share your slides.
Thank you so much, Neil. Good morning, good afternoon to all. Pleasure being there. Thanks so much for the invitation. So yes, as Neil briefly mentioned, I'm the technical lead for the World Health Organization's Global Health and Peace Initiative in Geneva at headquarters. Yeah, I think there's a lot to say about the Global Health and Peace Initiative and WHO's work linking health and peace, but I'll try to be brief. Some of the history of WHO's engagement on this thematic has been already recalled by Neil when he discussed some of the initiatives that took place in Latin America in the 80s, 90s. So I won't go back so much into the history, but let me walk you through what we're currently doing, what we're practically talking about as well. So first, beyond everything we've said, I think I don't need to preach the convinced here, and I think the various experts that have spoken have very well illustrated why it's important to link health and peace, or why they are intrinsically linked, actually. But from a WHO perspective, it's a real question, and it's not always something that there has been consensus on. So it's an important question. So from a policy point of view, there's four major references or justifications. First, it's the WHO Constitution that links health to peace and security as sort of a social determinant to health, as well as the Ottawa Charter, as has been mentioned. And more recently, the humanitarian development peace nexus, or the triple nexus, has been something WHO has engaged on, as many other development and humanitarian and peace building organizations. So I think coming in with an initiative that tries to more actively link WHO's development and humanitarian health work with peace efforts also resonates with the HDPN. And last but not least, from the same year in 2016, the UN General Assembly and Security Council adopted two twin resolutions on sustaining peace, which is basically which sort of makes the basis for the sustaining peace agenda of the UN, which is, together with the new way of working of the World Bank and the UN, a sort of invitation or a call to all UN agencies to actively contribute, or more intentionally and more actively contribute to preventing conflict and sustaining peace through our respective technical mandates. So the Global Health and Peace Initiative very much is a contribution to the sustaining peace agenda, as well as the HDPN. Now, from an operational point of view, there's a strong justification as well. It can't just be at policy level. And numbers are sadly striking, as you can see on this graph. Conflicts account for about 80% of humanitarian needs globally. As has been discussed, they are a major cause of health issues, not to say, of course, death, of morbidity. And also they have a strong impact on healthcare systems, while peace, on the other hand, enhances health outcomes. I think there's a strong justification for WHO, knowing WHO has had an emergency program now for several decades that basically is mainly busy responding to health emergencies in conflict settings. So based on that, our conclusion is, well, we cannot work ignoring the peace and security, peace and conflicts factors that play out and that we interfere with without, if we're not more aware. We interfere with anyway, and we have to be aware of these interferences and mitigate risks of aggravating conflict dynamics, but also, if possible, do good, not just do no harm, but also do good and try to contribute to some peace outcomes. And of course, the reason why we're so engaged in this is also because member states are supporting of that. Member states are key stakeholders for WHO. It's a specialized agency of the UN, which is governed by member states directly, not by the Secretary General. So in 2024, member states passed a resolution, the World Health Assembly, that sort of endorsed the GHPI and that definitely validated 4 of the 6 work streams of the GHPI roadmap that had also been requested by member states 2 years prior to that, and that was noted by the previous World Health Assembly as well. So we've got a strategic framework, which is the roadmap that was requested by our member states and that was actually designed in consultation with them and with other stakeholders. Now, going into the substance, I won't go into many details because a lot has already been said on this, including by Neil, but it's important to recognize that what we mean by peace mainly refers to social cohesion more than political peace. We're talking of strengthening trust, resilience, contributing to reconciliation, well-being as foundations for social and political peace in the long run. So, of course, everything is linked. We are not completely excluding peace at a higher level either, such as, for example, when WHO facilitates interstate collaboration over public health issues of international nature, which builds bridges between sometimes states that are in tension, if not in conflict. So we're not excluding other levels, but this is our main focus. So what is the purpose of WHO's Global Health and Peace Initiative in a few words? It's quite straightforward. It's about strengthening or improving the role of WHO and the health sector as contributors to improving the prospects for peace. For example, by strengthening programs' conflict sensitivity where needed, or contributing to various types of peace outcomes, as I've mentioned earlier on, or improving access to healthcare for populations affected by conflict in the framework of our mandate, of course, and under national ownership, because again, we are serving our member states first and foremost. And we are first and foremost a health organization, obviously, but there's a lot we can do in this framework. So what's the theory of change of the Global Health and Peace Initiative? What are you trying to achieve? So we say basically, if individuals and groups enjoy equitable access to health services, physical health, mental health, and if health actors design health interventions that promote trust and dialogue, that are conflict sensitive, if communities are empowered to cope with violent conflict and its consequences, then health coverage is more universal, grievances can be heard or better heard and better addressed to generate trust regarding emergency health concerns or access to healthcare in general. Affected communities are more likely to make meaningful contributions to peace and reconciliation and resist incitements to violence. As you can see, there's various levels of intervention that are sort of displayed in this theory of change. By doing what? By improving citizen and state cohesion through health equity, by facilitating cross-line cooperation in health governance. So again, here it can be between states, or it can be between non-state actors, or between a non-state actor and authorities. And by promoting health and well-being through dialogue and inclusion, can be at community level, between or within communities. It can be between health authorities or the broader government and population groups, can be at various levels here as well. How do we make this happen? Our key instruments and key concept in the GHPI is the health and peace approach to programming. And basically, this is the main added value to the GHPI. It's bringing in this new approach based on, of course, lots of peace building theory and practices. We haven't made that up at our level only. But basically, we're talking of integrating a tweak to the way we're working. This is really what it is about. And this tweak, this approach has 3 components or steps. First, of course, is making sure that in our work at country level, of course, mainly in conflict-affected or fragile settings, but not only, that we have thorough understanding of the context, of the social, political, dynamics that play out that contribute to peace or that contribute to tensions in societies, if not to conflict. So that's something that needs to be done in the needs assessment phase or risk assessment phase and throughout any program, obviously. Based on that analysis and our enhanced understanding of the context and all its complexities, especially in conflict settings, I think this is extremely important to be recognized. Then we can design and implement interventions or programs that are more sensitive to peace and conflict dynamics in order to do no harm. Going back to that very now old but very valid concept and principle for international cooperation. So what does this mean in practice? Conflict sensitivity means look at your team's composition. Are they representative of the communities you're working in? Or are they representative or a dominant group in society? And maybe they don't speak all the languages that are to be found in those communities. How is the team aware of the conflict and peace factors that they need to pay attention to and not fuel? Looking at beneficiaries, how do you target the beneficiaries? Are you actively making sure that this is very equitable, very inclusive? Are we not replicating marginalization patterns without being aware of it? And it can easily happen. You may be working with national staff or local partners that have their own bias in a national context where there's been decades of conflict or tensions between groups. And maybe your interlocutors are not completely neutral in the way they advise us, and they play a key role. Let's be honest. How do we implement the activities in general? What's the narrative? What are the attitudes? So anyway, there's a lot to say about conflict sensitivity. I don't think it's the objective of today's discussion, but these are just illustrations to show that there's many components to this. Peace responsiveness would be the third step. And we often say that this is something that we may not do. We may do or may not do. It's a decision that needs to be very much based on context, on political sensitivities, opportunities and needs. And we are not there at headquarters to develop a nice approach that may not be applicable in some contexts. We always say this is only valid if appropriate in a given context. So peace responsiveness, it's a concept that was articulated by Interpeace and Peace Building International Organization. That basically means how can a humanitarian or a development agency contribute to peace outcomes through its respective technical work. So that's what we're talking about. So there's various levels of engagement for us for the theory of change and in the application of the health and peace approach to programming. There's, in diplomacy, as also Neil mentioned, we use various tracks, and without going into the many other levels of tracks that were mentioned and that were brilliant. In peace building, at least, we often mention three main tracks, which is track one, which is a sort of high-level official one, where we can engage with government leaders over public health policies and collaborations. Track two, which is at intermediate level, engaging influencers such as leaders of conflicting parties or key health stakeholders, influencers who can encourage the resolution of an issue. Can also be just influencers such as faith leaders, religious leaders, and others. And track three would be at community level, which is where we work the most through this initiative and in general, where we can promote more resilience and empower communities on both health and peace.
Yeah, Mathilde?
Yes.
We're probably going to have to wrap up this, although it is rich and I wish we had more time. But
sure.
yeah.
Okay, no problem. So maybe let me walk you through this slide and the next one and conclude here. I think this is quite interesting because it provides illustrations of what this can look like in practice. So what type of peace outcomes can health programs really contribute to? You've got on the left the outcomes and on the right the various activities. So we're talking of reducing exclusions and strengthening trust at the vertical level, reinforcing social cohesion between and within communities, for example, by promoting access to mental health and psychosocial support, or through community dialogue over health issues, which we've done in many instances, same for MHPSS. Preventing violence repetition, supporting reconciliation processes at community level, including by supporting the reintegration of former combatants in the healthcare system, or just through other health-related activities. Or doing cross-line dialogue, such as disease surveillance and response in order to facilitate rapprochement and build confidence between parties to a conflict. Polio vaccination campaigns have been strong examples of this, for example, in Afghanistan, notably. Facilitating temporary humanitarian ceasefires or negative peace can also be considered as an interesting and important outcome for communities at risk. And of course, fostering cooperation, as I've mentioned, between countries through collaboration over health emergencies and higher level dialogue. I think I'll stop here. I was going to go through a few examples, but I'm happy to take questions later on. But here on this map, you have a short overview, a quick overview of where we've been either directly or indirectly linking and integrating health and peace outcomes in our work. Thank you so much.
Okay, thanks, Mathilde. We also have Noemi, who works with you from the Swiss government point of view. She might want to add something a bit later, but I do want to move us into the concluding phase because we actually have to end 10 minutes early because of some things at the CUGH end. So as we move things together, I see there's a lot of rich discussion and questions in there with people from different zones of conflict, a few questions from Haiti, and then others asking about CHWs, people asking about things in terms of Gaza and Physicians for Human Rights Israel. And I don't know whether we're going to get to all of those. I'm going to move back to sharing my screen, and then I hope to come back to the panelists as they look at the questions and comments for one last response, and Noemi can also respond at that time. So as we go through here, so just for the answers to some of your questions, there are a number of resources, books, magazines, and once again, you can write to any of us to find out about some of these things. WHO has had a number of papers, in particular WHO EMRO. There are things related to health diplomacy, which some people have talked about, and skills, again, related to that. Interestingly enough, though I mentioned the humanitarian ceasefires in El Salvador, what the people who developed Health as a Bridge to Peace in PAHO wanted to stress was that really was a small part of things. They actually thought the government-to-government cooperation across the political spectrum with El Salvador, Nicaragua, as it related to infectious disease and health information was equally important. And we can talk about that. I wanted to stress that, there's a whole set of courses that people can take on health diplomacy. But we also have to think that a lot of the way that we've developed things over the last many years, it's been more the northern savior type of thing, the white savior in some ways, with those of us from institutions in the North there to tell people in the South how to have peace. And of course, I think in the last 10 years, there's a lot more discussion about that. And I'm going to skip through this about the HDP nexus that Mathilde also referred to, but it does seem like peace through health is part of how WHO EMRO, which hosts a lot of conflicts, is looking at things. There are courses that WHO has had, such as the executive course in Dubai that I was part of. There are courses in Iran, in Shiraz. I am now on the advisory board of the Arab American University of Palestine. There's something called Medical Peace Work, which International Physicians for the Prevention of Nuclear War is promoting. They just had a recent new version of this course, which is available freely online. And then I taught a course in Konstanz, Germany, for political science and international relations students. And then we had our courses with McGill for a few years online. More than half of the students were from the Global South. For that whole political piece, social cohesion piece, and evaluation for what Carmel asked about evaluation, Anna Patterson, whom I mentioned in the chat, has a way of viewing this in terms of small p and large p piece. So the small p being a little bit of the social cohesion, more micro level things, and Bree put something in the chat. I wanted to mention a little bit about our Pegasus Institute on Peace, Global Health, and Sustainability, where we did offer the course, and you could look up pegasusinstitute.ca. As I mentioned, the course with McGill had a few courses also on environmental health and migration and health. And we did the courses in French and in Spanish. I saw we had a couple of questions from Haiti. We're going to have a conference at the beginning of May, and I hope that many of you can participate in that. We're talking about themes of health equity at home, health without borders, building peace, protecting health, planetary health and justice, and global migration. And we will have some work during the conference in French, and then with a pre-conference on climate change, we'll have a half day in Spanish. A number of speakers, including Ali Ardalan from WHO, EMRO, Yara Asi talking about Palestinian health, Keith Martin, who is the ED of CUGH, and many others with experience in zones of conflicts. Rachel Thibault, who's currently working in Ukraine on peace building. James Achuli, a young student from South Sudan. So for those interested in conflict and health, I'd recommend that you consider coming to the conference. Bree should also be there. I'm hoping Kaveh could be. Mathilde seems less likely, although we will try to get her in remotely if we can. We'll have Malala's father, Ziauddin Yousafzai, also there. You can still submit calls, submit abstracts for another week or so. So please, please consider joining us. Oh yeah, no, I'll end here, I think. So lots to discuss, but I want to give our panel one more chance to respond to stuff in the Q&A and chat. And so you can put on your videos again, panel, and we'll go one by one. Maybe I'll start off with Noemi if she wants to reflect on anything, having worked a bit with Mathilde and thinking about other actions, and then we'll go through with Kaveh, then Bree, then Mathilde. So Noemi?
Hi. No, I mean, I've just since I joined so late, really, I don't want to take away the time for the other panelists and also the questions that have been asked. So, really, go ahead. Also, since I really joined late, so I'm and it's okay from my side. Matilda, I'm sure, said everything about the Global Health and Peace Initiative. So, thank you.
Okay, great. Yeah, why don't we go to Kaveh? He's been answering some questions, as has Bree in the chat. But Kaveh, anything else you wanted to elaborate on in your answers or in
Well,
response to other
the
people?
main thing that comes to my mind is what I mentioned briefly, which is schools of public health, I think, need to bring far more attention to this topic of how armed conflict needs to be addressed. It is, when I teach the course, of course, I always start by saying, obviously, armed conflict is deeply political, but and we cannot solve it. It's not like we can bring peace to armed groups, but it's not something we should ignore. We should not say, oh, because it's so political, there's nothing we can do. There's plenty we can do and we should do. And I'm very proud we have a new dean at our School of Public Health, Dr. Megan Rani, who's focusing on reducing gun violence in the United States, which is an epidemic. And she's the first one who is really focusing on this. And of course, gun violence is also deeply political, but it should not be ignored, right? So, yeah, I always want to encourage other schools of public health to bring attention to this, not to be too nervous about the political aspect of it, and just teach courses, train, doing exactly what you are doing. So I really appreciate that. And yeah, that's my goal is to encourage other schools of public health to step up and pay attention to this.
Yeah, thank you, Kaveh. So Bree.
Yeah, I've been trying to answer Jane Mourinho's question, which is so interesting, and it really fits along what Kaveh was saying as well about this idea of, everything is very political, and I think there's always that I mean, there's been this tension for decades of, or even more, of how to provide care and how to address these inequities and terrible things that are happening in the world while still maintaining neutral. And I think that we need to kind of rethink what that looks like. I think in the wake of the current context of the conflicts that we're working in right now. And I think that idea of kind of like how these restrictions can really prevent us from fulfilling what our ethical duty is as public health practitioners or as social workers or as humanitarian aid workers and things like that. I think we have to think about that tension and what neutrality means, what activism means, and what those constraints are that we're dealing with. Every context is going to be different. What we're talking about, or what Jane's asking about with Gaza and Israel, is not unique. I think that this has happened with after Rwandan genocide in Goma. It's happened in every place. I mean, there's always examples of that, and it kind of reflects this global structural challenge that we need to talk about as humanitarian workers and as researchers, as public health professionals in this highly politicized environment that we're working in. So, but yeah, and I'll just end by saying I think the thing that to do, or at least what I try to do, is just stay true to I try to stay true to my own ethics, my own moral compass and what I'm doing. And that helps to kind of be a rock which to kind of grab onto. So thank you.
Yeah, thank you, Bree. And yeah, answering specific questions about Haiti and about Palestine. There are things that Bree and I, at least, are involved with in Palestine, where we're working with different organizations, but we can chat with people about that separately. Mathilde, really briefly, 30 seconds, and then we'll have to conclude.
Okay, that's easy. No, maybe I want to pick up on the evaluation question that was put in the chat. But unfortunately, I don't have a very strong answer right now. But I think it's a very important question that WHO is. So my answer is WHO is willing to work on this probably this year and next. I mean, of course, over several years. So if there is interest in this group for contributing to monitoring and evaluation efforts, and meaning when I say this is developing an M&E framework, a generic one that can then be used in a way that's adapted to every context where we link health and peace on the ground, then we're very interested in, and would happily contribute to those stakeholders who have some experience and thoughts on the matter. So yeah, big file, very important one. And we want to address this as of next year more systematically, let's say, than we've been able to do it until now. Thank you so much.
Well, thank you, Mathilde. And I wish we could have talked about your examples with more time. And again, we hope to do that at our Pegasus conference. Ian's also mentioned the CUGH conference and sessions there. So we should have time to continue this discussion in academic fora and hopefully get more courses, as Kaveh was talking about. So please do correspond with all of us. Thank you all for coming as panelists, some of you at very short notice. Thank you for the audience. I think that all of you, I saw so many really thoughtful comments, and I hope that we can continue to be engaged. So please do write to us and try to attend our events. Thank you, everybody.